Good evening. Yet another episode of Journal Journey, our academic feast. And this time there is one more feather in the cap. And we are getting 1 MMC credit point with this. I am extremely delighted to present to you today's episode, which is on liver. I hand over mic to MOC Dr. Swati Likhite.
Thank you, madam. Good evening and warm welcome to all the doctors present here. It's my privilege to anchor today's session of Journal Journey. Maha-IP and Raigad-IP invites you all for today's session. We have two important topics to be discussed today. The first one is clinically meaningful body mass index change impacts pediatric non-alcoholic fatty liver disease. And the second one, acute liver failure in children. I'm sure the discussion and the presentations are going to be just awesome. First of all, I would like to invite Women's Forum co-chairperson Dr. Neha Singh to welcome our guests. Over to Dr. Neha.
Thank you, Swati ma'am. I welcome all the respected dignitaries for today's Journal Journey. I welcome Dr. Ramakant Patil sir, Maha-IP President and Central IP EB member. I welcome Dr. Amol Pawar sir, Secretary General Maha-IP. I welcome Dr. Hemant Gangulia sir, past President Maha-IP. I would also welcome our guest of honor, Dr. Vasant Kalatkar sir. I would welcome our expert of today, Dr. Vishnu Biradar sir, and Dr. Vikas More sir, President, Raigad-IP, Dr. Ajay Kohli sir, Secretary, Raigad-IP, Dr. Chitra Kulkarni ma'am, Dr. Sunita ma'am, Dr. Swati ma'am. I also welcome Dr. Renu Boralkar ma'am, Central EB ma'am member. Now I hand over to Dr. Swati ma'am.
Thank you, Dr. Neha. Now I request Maha-IP President, Dr. Ramakant Patil sir, to address everyone.
Is traveling.
Hello. Good evening. I again congratulate Raigad-IP, Dr. Vikas More, Dr. Ajay Kohli, my EB colleague, Dr. Renu, the backbone of this journal journey, Dr. Chitra Kulkarni, and our guide, Dr. Nimen Mohanty. I also recognize and mention the presence of past president of Maha-IP, Dr. Hemant Gangulia. I am very happy to see a guest of honor, my friend, Dr. Vasant Kalatkar, and today's expert, Dr. Vishnu, and the two presenters of the article. What we have seen, Dr. Vishnu will enlighten us on that, but there is a definite shift of epidemiology of acute liver cell failure, and we are seeing more and more causes of non-hepatotropic viruses and metabolic diseases in acute liver cell failure. And this jargon of NAFLD will be further decoded for us. And in the spate of this adenoviral infection and adenoviral associated infections, it is going to be causing a real problem. And some patients we are getting in multi-organ failure with the I had nearly 3 patients in the last 3 weeks who had adenoviral infection on biofire, and they had pneumonia, diarrhea, encephalitis, and hepatic encephalopathy. So with the ALT and AST in up to 7,000 and real liver cell failure. So we are eager and all ears to listen to this presenters of article and enlightenment from today's expert, Dr. Vishnu Biradar, and Dr. Vasant Kalatkar will give us his experiences on said topic. So, thank you, Dr. Chitra, Dr. Neha, and today's moderator for giving me an opportunity to have word with you. Thank you. Hand it over to today's compere. Thank you.
Thank you so much, Dr. Ramakant Patil sir. We acknowledge the presence of our MMC observer, Dr. Vaibhav Pustake, for today's CME. Good evening, sir. Now, I invite Maha-IIP Secretary Dr. Amol Pawar to give his blessings and introduce and welcome our today's guest of honor, Dr. Vasant Khalatkar sir. Over to Dr. Amol.
Is Dr. Amol present? Yeah. Dr. Vasant Khalatkar is a bright student, as I know. He is from Nagpur and he has done PG diploma in infectious diseases and fellow guide diploma. He is having a flourishing practice in Nagpur, a past EB CIAP 2009-2010 and editor in Pediatric Neurology Bulletin. And he is presenting lot of papers in various national and international journals. I wish him all the best also and request him to share his thoughts about our journal journey. Dr. Vasant.
Yeah, good evening, everyone. And thank you, Chitra Madam, for my introduction. She was seniors. I think who knows better than senior. I think Chitra Madam was the best person to know me since my studentship.
Yes.
And thank you, Madam. You are having very good opinion about me. Really. It may not be, she might have seen me in presenting journal. That's why. So, really, it's a revival of Journal Club. Today's mainly Dr. Ramakant Patil, our national EP member with Maha IP President, Dr. Niman Monti, Dr. Enu, all the Dr. Vishnu Biradar, and all my friends. Really, I want to congratulate this Raigad Academy. Always they are in forefront of this type of activity. And today's activity, we are really going to get something. Because I know since us in my life also, I lost the touch of this journal because of all this media and everything. So still, we are getting it all in our CME and from our internet and from Google Baba. But actually, listening from the experts' comment and experts' mouth, it's really good because that gives you the visual impact. So I request Dr. Chitra and Dr. Neha and all these Raigad fellow, please do continue this activity. Swati Madam is there. She is, I know they all are hard worker. So, and my special request for all the delegates, all the viewers today present, please make it viral next time. I tried to make it viral everywhere. I'm having so many groups, and it should not be limited to Maharashtra only. I want to try it viral to all over India. So next time we will make it viral, and I think we will get a good more than this. But this number is not bad. At present, I am looking at near about 60, 70, but this number is not bad. And those who are interested, definitely, I wish all the best to Raigad IIP and this journal journey. You will get best of the best from this journal. Thank you.
Sir, the activity is upgraded to Maha IIP now.
Yes.
Over to Dr. Swati.
Thank you so much, sir, for the encouraging and kind words. Now I invite our Raigad IIP President, Dr. Vikas More, sir, to welcome the dignitaries.
Thank you so much, Swati Madam, for giving me the opportunity. At the outset, I welcome all of the dignitaries, especially Ramakant Patil sir and Vasant Khalatkar sir, my dear friend Dr. Vishnu Biradar, who we both are room partners, Dr. Vaibhav Pustake sir, who is MMC Observer. Thank you so much, sir. And especially Dr. Bharti Khairnar and Dr. Amit Chavan, who will be presenting the case today. We know that this journal journey is going on since last almost more than a year, and it is being successfully conducted just due to the constant motivation by our respected Mohanty sir without which this activity is nearly impossible for us. And at the same time, we have a very strong team like Dr. Chitra Kulkarni Madam, Dr. Neha, Dr. Vishal, who constantly work to make this happen every monthly. So, as an IP president, I have some suggestions that every month, if we like target some different systems, like with this month we targeted the lever, then next month some another system, so that we will get the different articles for different systems. And if it is especially useful for our general pediatricians, then also it will be more helpful. Right now, the kind of articles which are being discussed are excellent at par. So these are the various feedbacks which I'm getting from all over India, which I wanted to share. Thank you so much for being with us, and I'm so happy to be part of this journey. Thank you so much. Over to you, Swati Madam.
Thank you so much, Dr. Vikas. Now I would like to call upon Coordinator Dr. Jay Bhandarkar sir to introduce our today's expert, Dr. Vishnu Biradar sir, and then the first speaker of today's journal journey, Dr. Bharti Khairnar. Over to Dr. Jay.
Hi. Thank you, Swati. It's my pleasure to introduce Dr. Vishnu Biradar. He's a gastroenterologist and fellowship in pedic done liver transplant in UK. At present he's a consultant at Jupiter Hospital, Pune, as well as Kambal Endoscopy Center, Shivajinagar. His major achievements, his Isbagan Internal Travel Exchange Award in 2018-19, and has presented many papers, posters, publication in national and international platform. Thank you. And also, today's the first presenter, Dr. Bharti Khairnar. She's a pediatric consultant from Manipal Hospitals, Kharadi, Pune. I also welcome her and thanks for accepting our Maha IP and Raigad IP invite as a speaker. Thank you.
Thank you so much. I would like Dr. Bharti to start her talk.
Shall I share my screen?
Yes, madam.
Can you see my screen?
Yes.
Am I audible?
Yes.
At the outset, I would like to thank Maha IIP and Raigad IIP for giving me this opportunity to present on the academic event on Journal Journey today. This research paper has been selected from Journal Pediatrics 2022, volume 250. Impact factor of the journal is 4.066. Title of my presentation is Clinical Meaningful Body Mass Index Change Impacts Pediatric Non-Alcoholic Fatty Liver Disease. This paper has been selected looking at increased incidence of Western diet in Indian children, leading to increased incidence of obesity and overweight. Next slide, please. Pediatric non-alcoholic fatty liver disease, NAFLD, is the very common in children with obesity, leading to cirrhosis and end-stage liver disease. It is the most prevalent liver disease of childhood. It is the fastest rising indication of liver transplantation in young adults. Lack of effective pharmacotherapy causes problem in the treatment. Lifestyle intervention in the form of diet, physical activity modification is mainstay of treatment. Goal of this study was to reduce reduce adiposity, especially visceral. Clinical assessment was done by improvement in body mass index, BMI, improved normalization of metabolic variables, serum aminotransferase levels, ALT were looked at. Objective of this study was to investigate prevalence, characteristics, and hepatic outcomes of children with non-alcoholic fatty liver disease, NAFLD, to achieve a BMI Z-score reduction of more than 0.25 from baseline, to determine BMI Z-score reduction associated with ALT normalization. In the methods, it was a retrospective study at Cincinnati Children's Hospital Medical Center. Data collection was done from electronic medical record. Inclusion criteria were age between 0 to 18 years, follow at steatohepatitis clinic for presumed or confirmed non-alcoholic fatty liver disease, NAFLD. Time period was between January 1st, 2010 and 30th June 2021. Exclusion criteria were weight loss surgery, conditions that may be associated with weight loss, example malignancy and pregnancy, that may be followed after the diagnosis of NAFLD during the timeline of visit. Presumed non-alcoholic fatty liver disease was defined as hepatic steatosis on imaging and or elevation in serum aminotransferase levels in patients with overweight or obesity. Negative workup for other causes of liver disease, example Wilson disease, autoimmune hepatitis, hemochromatosis, alpha-1 antitrypsin deficiency, viral hepatitis B and C. Confirmed non-alcoholic fatty liver disease was defined as histologic confirmation by liver biopsy. Data collection was done at 2 time points: baseline steatohepatitis clinic visit and clinic visit with lowest BMI Z-score following baseline visit, as long as the latter was more than 90 days from baseline, to see impact of clinical intervention. Variables were demographic characteristics such as age, sex, ethnicity in the EMR. Clinical characteristics were BMI and BMI Z-score. Laboratory characteristics were ALT, AST, GGT, alkaline phosphatase, hemoglobin A1C, total cholesterol, low density lipoprotein cholesterol, HDL cholesterol, triglycerides, creatinine, BUN, and uric acid. Intervention was done at the center. Patient received standardized lifestyle advice for the treatment of NAFLD as per guidelines of North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. In diet, elimination of sugar-sweetened beverages was advised. Consumption of a portion-controlled, age-appropriate, well-balanced diet. Physical activity with goal of daily moderate intensity exercise. Patient may meet registered dietitian for guidelines. Statistical analysis, multiple logistic regression analysis with stepwise variable selection done to identify predictors associated with outcome. This table shows patient characteristics at the baseline visit. Cohort was of 784 children. Median age was 13 years. 66% were males. 24% were Hispanic. 541 had lowest BMI Z-score at more than 90 days following the baseline clinic visit. Of 784 children, 541, 168, that is 31%, had a BMI Z change more than or equal to 0.25. Decrease in serum aminotransferase and lipid levels seen in both the groups with and without a BMI Z score change of more than or equal to 0.25. Hemoglobin A1C did not change in either group. Young age and non-Hispanic ethnicity were predictors of this outcome, that is BMI Z score of more than or equal to 0.25. Sex and presence of type 2 diabetes mellitus at baseline did not show effect on BMI Z score reduction. In the discussion, 1/3 of children with NAFLD achieved a BMI Z score reduction more than 0.25 from baseline lifestyle advice alone. Young age and non-Hispanic ethnicity where baseline variables could achieve the goal, that is reduction in BMI Z score by more than 0.25, improvement in markers of the liver disease severity and metabolic dysregulation. BMI Z score reduction to achieve normal ALT was 0.27 in pediatric cohort. This is close to clinically recommended for obesity management. Time to achieve this goal was 1 year. Most patients were not successful in achieving an adequate BMI Z score reduction, and increase in BMI Z score and liver enzymes were seen following the time point of lowest BMI Z score. Hence, this study underscores the need for pharmacotherapy for pediatric NAFLD. In the discussion, HbA1c did not show change as median HbA1c was in the normal range, and this was too brief time frame to see a change. It is important to screen children with NAFLD for pre-diabetes, diabetes development, even if they are improving from liver markers perspective. Strengths and limitations of this study. Strengths were large sample size, inclusion criteria selected on a bias. Limitations of this study were it was a retrospective design. There was a lack of information on data like race. Ethnicity data were self-reported at the time of patient arrival in the clinic and were not taken with the same rigor as it would have been with the prospective study. Lack of histology and or imaging data from clinic visit with lowest BMI Z score. Impact of BMI changes on liver could not be assessed. So in the conclusion, BMI Z score reduction of more than or equal to 0.25 is associated with significant changes in serum aminotransferase levels. These findings can guide clinical management of children with NAFLD. For the scope in future studies, investigation of socioeconomic and educational barrier which may affect the successful implementation of lifestyle advice offered in the clinic. Take-home messages. NAFLD is the most prevalent liver disease in childhood. Every child's BMI should be assessed in clinic. Detailed history about diet and physical activity should be taken in children. Children found to be overweight or obese should be advised age-appropriate diet modification, physical exercise. Follow-up at regular visits should be done to monitor for change in BMI. Thank you.
Thank you
Please
so much,
stop
Dr.
share.
Bharti.
Please stop share, ma'am.
Thank you so much, Dr. Bharti, for a very informative, interesting, and simplified presentation. Now I request Dr. Vishnu sir to give his comments.
Yeah, actually, this is very good study, and yeah, if somebody can, Bharti madam can guide us about the why BMI Z score was chosen, not as a BMI. Can you guide us, madam, about it?
Sir, I would like to say some facts which were mentioned in this article.
Yes.
So this article mentions about lifestyle modification in the form of dietary advice and weight loss. So in adolescents with obesity who have attained their adult height, it has been shown in the studies that achieving more than 5 to 10% weight loss is desirable.
Correct.
In younger prepubertal patients, treatment is usually aimed at weight stabilization, depending on the severity of obesity, age, and sex, because ongoing linear growth also contributes to BMI improvement. And reduction in BMI Z score provides a measure of BMI change by age and sex. That is why they have taken BMI Z score reduction as a criteria. And also in this research paper, it was mentioned that it is seen in the adults. 5% weight loss is associated with reduction in the liver fat content, roughly corresponding to 50%, and 9 to 10% weight loss is associated with resolution of non-alcoholic NASH, non-alcoholic steatohepatitis, as well as regression of fibrosis. But in the children, because they attained height at the puberty, you cannot aim at weight loss. So
Correct,
BMI
correct.
is looked at.
So the Z score, that is why it is important. But the problem with the BMI Z score is that it is not the correct interpretation of the fat distribution in the body. So the same author has came up with the same data. They came up with a different article, and that article mentioned that BMI Z score is not synonymous with the fat reduction in the overall body or the visceral fat, but at the same time, reduction in the weight, all we are aware about is it is very, very essential to get rid of this fat. And as a transplant unit, we are always advise when there is a fatty liver in the family and the mother or father is donor, then we advise to tell them to lose weight. And there is one paper which has said that within 3 months, the fat from the hepatocyte also goes down, the inflammation also goes down, and the fibrosis also gets reversed. So that's the beauty of reduction in the BMI. The only problem this paper had is that very short-term follow-up of 2 years, because as we all are aware about, the first 6 months or 1 year, the parents are motivated, the child is motivated, but as the years goes, then after a reduction of 5 to 10%, again they will come back to the normal, and that is why the long-term follow-up is very essential. One more point which was mentioned in this article was there is a difference in the result when the child is young and child is older. Can you comment on that, madam?
Sir, the difference is because young children are developing and their diet control is partly by their parents who are still developing their lifestyle habits. But in older children, it is difficult to restrict diet.
Yes, yes.
So younger children, the study has shown good result with younger age.
Because parents has the control on the diet, and that is why it is very.
And also younger age is easy to address about the issues with the obesity.
Yes. Back what was there before also about the weight loss, but the outlook should be not the weight loss, but the BMI Z-score, not the BMI, particularly in the pediatric age group, not as adult. We have the another point was that can we discuss about some few tests which has applied in this case while taking this statistical analysis? Can we go through some of the tests, what they have done the statistical analysis through which? Means I know that this is not relevant in the clinical practice, but it is always useful to brush on the some of the tests which has been done, like what is the t-test, what is the paired t-test, what is analysis of variance, ANOVA test, or what is the univariate logistic regression test, what is multivariate logistic regression test, or a Kaplan-Meier test. So can we just have a few comments or the discussion on this before going to the next talk?
Yes, sir.
Dr. Vishnu, you can enlighten us on that scores, because he will not be in a position to discuss this. He has not prepared.
Yeah, briefly, whatever I remember, I will just mention. The paired t-test is between the two. Mean between the two should be, is it significant or not, that we see with the paired t-test. ANOVA, that is analysis of variance, which should be between the 3 different or 4 different groups. Then the mean needs to be analyzed with the ANOVA test. And univariate logistic regression is when there is only one only one intervention is looked. What are the results of that interpretation, the intervention in that particular case? Then it is univariate. But when the multiple points are looked at, then it is a multivariate logistic analysis. And the Kaplan-Meier test is simple test that tells us that by reducing this BMI score, whatever the children which achieved the normalization of the ALT, what is the survival? Means those who have not reduced the BMI and those who are reduced the BMI, what is the long-term survival? That is what we do in the Kaplan-Meier test. So these are the few things I thought just a journal club. So for our understanding, we should just discuss 1 or 2 points so that we learn from each other.
Yes. The most important thing Dr. Vishnu has brought out is that in a growing children, absolute BMI is not important. More important is Z-score. That is it. What is the tracking? The way the BMI is increasing, that track is more important than the absolute BMI value in a growing child.
Yes. This study has some fallacies also, because as a non-alcoholic steatohepatitis, what we see is the ALT and AST does not always mean that the hepatitis, steatohepatitis is under resolution. Okay? So sometimes you have a normal ALT, but there is an inflammation in the liver. And that is why she mentioned also in the limitation that there was no biopsy done at the time when there was a lowest BMI Z-score. And it is impossible to repeat it. But that is the fallacy or the limitation of these studies.
Can CRP indicate some inflammation ongoing?
If it is an inflammatory disorder, then yes. But if it is not inflammatory disorder, then CRP does not always come as a marker of inflammation. It was
Okay,
very
sir.
nicely presented. Yeah.
Thank you. Shall we move on to the second topic now?
Yes.
Yeah.
I would just like to thank Dr. Vishnu sir for giving his guidance and also sharing his thoughts. Now I invite Raigad IIP President Dr. Vikas More to introduce our second speaker of the day, Dr. Amit Chavan.
Dr.
Swati.
Vikas?
Yeah,
Dr.
Dr.
Vikas?
Vikas More.
Swati, तुम्हीच करा introduce Swati.
Okay. Dr. Amit Chavan, he's a consultant and pediatric intensivist at Kolhapur.
Yeah, sir has passed his MBBS in 2000 and DCH from NM Wadia Solapur in 2003. And he is a pediatric critical care consultant from Nasik University and working in intensive care from 2004. He worked in Valavalkar 2004 to 7, Manikikar Hospital, Pune in 2007 to 2011, Komal Pediatric Intensive Care in Kolhapur from 2011 to 19, and right now he is in Masai Hospital PICU Kolhapur. Welcome, Dr. Amit.
Thank you, madam. Shall I share my screen?
Yeah, please.
I first thank you, Maha IIP, as well as Raigad IIP, as well as the Kolhapur Academy of Pediatrics, to give me the opportunity to share my views on this or this journey. Today, I am going to read the review article published in the PCNA in June 2020. Journal is acute liver failure. It is a review article. It is acute liver failure in children. So the first, the definition. They define acute liver failure as a coagulopathy with a INR more than 2 without hepatic encephalopathy, or more than 1.5 with hepatic encephalopathy due to the liver cause that is very much essential, and it is not corrected by the vitamin K. There should be a biochemical evidence of acute liver injury, and there should not be there is no evidence of chronic liver disease. Depending on the onset of jaundice to the development of coagulopathy and encephalopathy, they are divided it into hyperacute if it is less than 1 week, if it is acute if it is between 1 to 4 weeks, that is 8 to 28 days, and it is subacute if it is between 4 to 12 weeks, that is 1 month to 3 months. As the etiologies of PALF is various, there are drugs, there are toxins, there are infectious, there are infiltrative, idiopathic, genetic, and metabolic causes. Depending, there are various causes. The first is a drugs. Drugs has a two different mechanisms. One is a dose dependent. That is, more the dose, more will be the toxicity. The most common is a paracetamol intoxication. It is said that more than 100 mg per kg stat dose, or 100 mg per kg more than 1 day, or 15 mg per kg 4 hourly for more than 1 day, that you should suspect the paracetamol intoxication. The second drug, which this mechanism is a halothane. The second mechanism is idiosyncratic, which is not dose dependent. the most common drugs are antiepileptic like valproic acid, antitubercle like INH, the antihypertensive amiodarone, anti-pyretic like mefenamic acid, allopurinol, antifungal like ketoconazole, and some of the analgesic like diclofenac. There are toxins which are like mushroom poisoning, which are not so much common in India, as well as yellow phosphorus and industrial solvents. There are infections, they are divided into two, viral and non-viral. In the viral, there are two different mechanisms. One is a direct hepatotropic virus, which causes a direct injury to the liver. Some like HSV, hepatitis A, B, B plus D, and E, cytomegalovirus. Well, there are various different type of mechanisms like development of myocarditis, development of shock, HLH, while some other also causes the LF, which without involving the liver directly. That is, it is a one part of multisystemic involvement. Like we have said that adenovirus, Epstein-Barr virus, varicella, measles, anaphylavirus, and dengue virus. These are most common viruses we will see. In the non-viral causes, there are salmonella, tuberculosis, malaria, leptospiral, as well as gram-negative viruses, and some non-viral infections like Bardotella. There is a ischemic causes, some like Budd-Chiari syndrome. Otherwise, whatever causes which are responsible for the decrease in the circulation or decrease in the blood supply to the liver or decrease in the oxygen supply to the liver, they all causes the acute liver failure, which is also called as a shock liver. There are causes like acute circulatory failure, that is cardiac failure like myocarditis, low cardiac output states like Fontan circulation, dysregulation, dysarrhythmias, and cardiopulmonary stoppage. There are, and the most common which comes is a metabolic disorders. These metabolic disorders like most common are galactosemia, tyrosine, hereditary fructose intolerance, mitochondrial cytopathy, fatty oxidation defect, and urea cycle defect. And in adolescents above 5 years, there is a Wilson disease. Some rare, but is a Niemann-Pick disorders, Niemann-Pick disease type C, antitrypsin deficiency, and inborn defect in bile acid synthesis. There are some causes which are called as infiltrative, some like HLH, leukemia, and lymphomas, as well as some is caused idiopathic. While this idiopathic is causing 50% of all the acute liver failure, these are some certain mechanisms which are caused by the cytotoxic T4 cells. Now, this etiology is also depending on the age. So, depending on age, of etiology it might be there. It is divided into different categories. That is below 1 year infants, between 1 to 12 years, and adolescents between up to 18 years. Now, if you see the infants, the most common causes, it is again divided into same, that is metabolic, infectious, ischemic, drugs, and infectious. If you see the infants, the more causes you should suspect are the metabolic and infections. There are also some causes like ischemics and drugs, but the drug is because of accidental poisonings. Infiltrative disorders like congenital HLH. If you take the age from 1 to 12 years, there are metabolic disorders come down, but the infections remains the same. And infiltrative causes what might increase, like secondary HLH and autoimmune hepatitis and leukemias, and some like ischemic disorders and drugs also. And the third, above 12 years. If you see above 12 years, only one metabolic cause remains is the Wilson's disease. Infective and infiltrative causes, newer causes like factor of pregnancy, and as we say, non-alcoholic fatty liver diseases, and ischemic, and some of the drugs. But these drugs are taken as because in the suicidal intentions, not as an accidental point. If you see the signs and symptoms, we know the basic signs and symptoms are jaundice, lack of appetite, malaise, haloperidol, vomiting, and abdominal pain. But it depends on what sort of patient will come to you. Majority of the patients which land up with the hepatic encephalopathy. In these cases, patient will see with the altered mental status, irritability, poor feeding, change in sleep patterns. And if you inspect the patient, the major is a jaundice, ascites, and hepatomegaly, which is called as acute liver edema. And depending on what stages the patient will come, there are various other signs like hepatic encephalopathy. There are various stages of hepatic encephalopathy, and this staging and grading in ICU is very much important. That depends that it will take the decision and urgently list the patient for the transplantation. We will see the details of this grading of hepatic encephalopathy. The patient might come with the vasodilatatory shock, and the patient may come with the bleeding. Although in acute liver failure, the spontaneous bleeding is less likely. So whenever there is a bleeding, mostly because of the trauma or surgical bleeding, and if there is a spontaneous bleeding, then you should suspect the sepsis and thrombocytopenia. Now, along with these signs of ALF, you should also see what are the etiological signs which can suspect the diagnosis. If you see if you're suspecting Wilson's disease, you should see for the KF ring. If there are vesicles are present, you should suspect HSV. Non-specific rash conjunctivitis, you should look for the viral. And if you have lymphadenopathy generalized, you should suspect HLH as well as malignancy. Dysmorphic feature, growth retardation, genetic metabolic. And if there is a foul breath, then it suggests advanced pediatric. Now, this liver failure doesn't consist only with the liver. It also causes the various damages to other systems also, which are part of the extrahepatic complication. And majority prognosis and whatever decisions you are taking, that is also depending on this extrahepatic complication. So you should know what organs are get involved and what is the basic pathophysiology. It will tell you how you should manage this patient. So if you see what are the extrahepatic complications, the first one, if you see the brain, it is causes the increase in the ICP as well as causes the cerebral edema and hepatic encephalopathy. In terminal stages of ALF, they have a respiratory failure. In cardiac involvement might be with the cardiomyopathy in terminal cirrhotic stages, or it will present as a vasodilatory shock. In kidney, it will involved with the hepatorenal syndrome and AKI. As we mentioned, it is a coagulopathy. As we know that it also stimulates the immune dysregulations and more susceptible for the infections, and various metabolic disorders like hypoglycemia, hyperkalemia, hypophosphatemia, metabolic acidosis, and respiratory alkalosis. The pathophysiology of each and everything is very much essential because it gives the clue for the treatment. Now, first we discuss regarding the hepatic encephalopathy. Now, as we know that hepatic encephalopathy occurs because of ammonia, and this ammonia is produced from the dietary proteins plus bacteria as well as the turners. Routinely, what ammonia goes to the liver and it's converted into the urea by urea cycle or Krebs cycle, and this water solubility is excreted in urine. But in case of ALF, this ammonia start rising. If this ammonia persists for so much long period and higher level, then it is taken by the astrocytes and it is converted into glutamine. Because of glutamine, there is an increase in the osmolality in the astrocytes. That's why there is an influx of water inside. Because of that, there is a cytotoxic edema as well as a raised ICP. But if you find the clinically, not always, the even low ammonia level can lead to the higher level of encephalopathy. So there should be some other things which is also responsible for that. If you see, there are some other pathologies like some protein-bound compounds like tryptophan, opioids, benzodiazepam, GABA, aromatic acids. They are also responsible for the raised ICT and ICP. So only ammonia is not responsible for the hepatic encephalopathy. These all protein-bound compounds are also responsible. As well as because of the injured hepatic cells, they releases major of a vasoactive substances as well as the cytokines. This is caused a disruption of a blood-brain barrier and influx of water inside the brain, and that is called as vasogenic edema, as well as it aggravated by the hyponatremia and causes the hepatic encephalopathy. So depending on what stages it is, you should treat. If you have to do dietary protein, decrease dietary protein, as well as start with the rifleximab and the lactulose. If the ammonia is high, you should, as it is water soluble, it can be easily removed by the CRRT, continuous renal replacement therapy. And like some protein-bound compounds cannot be removed by the CRRT. So all these vasoactive substances, cytokines, and all these tryptophan can be easily removed by the ELS, which is called as the extracorporeal liver support system. Now, if you see, this is very much important, that staging. Depending on that, you should treat the patient as well as decision to whether to transfer the patient or for the LT or not to be done. In grade 1, infants and children, that is unconceivable, irascible, the mother will tell me that this is not routine. As well as in adolescents and adults, there is a tribal lack of awareness, euphoria and anxiety. There is a decreased attention span. In this case, GCS will be around 14 and 15, and normal neurological examination or sometimes mild hyperreflexia available. Very few patients had a edema and EEG remains unremarkable. In infants and children in stage 2, the patient is drowsy and if arousable, it is uncontrollable, but it is more sleepy. It sleeps at unusual times. In adolescence, it is lethargy, apathy, and disorientation. And the patient will present with the GCS of 12 to 14 and hyperreflexia and tremors, which can be seen with the impaired hyperactivity. In this case, there is a 25% of patient had a edema, and there is a diffuse swelling on the EEG. Now, in stage 3, the infants were more stuporous, somnolent, and sleepy, while adolescents are also semi-stuporous and confused, disoriented. In this case, you should see the GCS around 8 to 12. It is hyperreflexia, and all cerebral signs like ataxia, abnormal gait, hand-eye coordination will be positive. In this case, cerebral edema are around 35% patients, and there is a triphasic wave on EEG. At this point, you should consider other pharmacological treatment to decrease the serum ammonia as well as the blood purification system. There is a 4A and 4B stages. In 4A, in infants and adolescents, patient is comatose, which is not responding to any type of painful stimulus. While in stage 4, they are they give response to painful stimulus. While in 4B, they does not give response to the painful stimuli. GCS around 3 to 7, a reflexive decerebrate and decorticate position, and all the signs of raised IC. 75% have a cerebral edema, and in this case, as we know, anything below 8, you should intubate the patient to for the airway protection, as well as all the systems that it is a prevent hyperammonia, and all these purification systems should act at this stage. Now, the second is a hepatorenal syndrome. This is another most common complication that happens. Now, why this happens? It is because of necrotizing hepatic cells. They causes rise in the circulating inflammatory mediators, as well as increase in the nitric oxide, toxin, bile acid. So what they will do, they will go, and there is a vasodilation in the splanchnic vasodilation. As we know that majority of blood rests in the splanchnic vasodilation. Because of there is a stagnation of the blood in splanchnic vasodilation, there is a relative hypovolemia. Because of relative hypovolemia, there is a less blood flow to the kidney, decreases the GFRs, and that stimulates the RAS, that is renin-angiotensin system. And because of that, there is a renal vasoconstriction and further decrease in the GFR. As well as because of increased sympathetic activity, there is a stimulation of ADH and absorption of more of water that gives a hyponatremia, which can increases the hepatic encephalopathy. Now, how this hepatorenal syndrome is defined? It is a grade 2, grade 3 AKI, which is always reversible if a primary liver failure returns to normal. Second, it is not associated with the morphological as well as histological damage, and it is not precipitated by the sepsis, shock, or any sort of hypertension. But if we don't take care at this vasodilation level, then further decrease in the GFR, and if this patient is associated with the infectious inflammation and nephrotoxic drugs are used, then this gets to the acute kidney injury. Depending on that, now how you should manage this? The first is, if there is a flanking vasodilation, you should resuscitate the patient with the isotonic fluids properly. Keep the map of that patient properly. If not responding, you can give 5% albumin and use of vasoconstrictor like norepinephrine and vasopressors. This is the first thing. Now for the AKI and HRS, you should increase, start with the CRRT. Third is for the circulatory inflammatories, these are protein bound that can be removed with the extracorporeal liver system. And if not at all, if various stages of ALF, then you could do the liver.
Dr. Amit, we can't hear you.
Yes. Can't hear.
No, we could.
Hello.
Yes,
Yes,
yes.
Am I
can.
audible?
Continue.
No, no,
continue.
you are audible, sir. You are
Dr.
audible.
Amit, we can't hear you.
We can
You are audible, sir.
Okay.
continue.
You are audible.
Okay. So what are the other manifestations? That is hepatic cardiomyopathy. This cardiomyopathy, what is called as a cirrhotic cardiomyopathy, found to be in adults in the terminal stages of fever. In adults, even if not in cirrhotic stage, in early ALF stage, there is a damage to the myocardium because of hyperinflammation. That can be evidenced with the high tropi and high level of NT-proBNP and echo. But this is not found to be in case of pediatrics. So hepatic cardiomyopathy or sort of damage to the heart is not found to be more in the children. as well as we discussed, it has caused vasodilatory shock. Now, the most interesting is a hepatic coagulopathy. As we know that all the cytokine proteins, that is a proagulant as well as the anticoagulants, they are produced in the liver. So because of ALF, there is a decreased level of proagulants like 2, 5, 9, 10, and fibrinogen, as well as anticoagulants like protein C, protein S, and antithrombin. But in this case, there is a prolongation of PT-INR. Okay, so majority of people thinks there is a risk of bleeding, but conveniently it is less than 5%. This is because as well as proagulant decreases, anticoagulants also decrease. So there is a rebalanced hemostasis. Okay, so if we actually see, it is a hypercoagulable stage. Because of continuous endothelial stimulation, there is a rise in valvular factor, as well as we know that factor 8 is not depending on the liver, it is produced by the endothelial cells. So because of that, there is a raised level of factor 8. So because of that, von Willebrand factor 8, it is actually hypercoagulable state. So we don't see a spontaneous bleeding in only acute liver failure. So PT-INR, so raised PT-INR, you should not give FFP. Okay, so PT-INR cannot be staged on the coagulability stage. So another test is a TEG, is a quantitative reliable test. So are there things, if there is a bleeding? Yes, if the spontaneous bleeding is there, then you should suspect some other etiologies, like because of sepsis, there is a DIC and thrombocytopenia, and because of that, there is a spontaneous bleeding. And in that case, you should give the FFPs. There are some metabolic derangement like hypoglycemia, which causes because of impaired glucogenesis and depleted glycogen stores. Hyperkalemia, hyperphosphatemia because hepatic necrosis, as well as worsen AKI. Hypophosphatemia occurs during the regeneration phase. So normal phosphate level should be maintained. Acidosis because of active hepatic necrosis, shock, increased atomic metabolites, and IM. Alkalosis is because of hyperventilation in early stage because of IM and raised ICP. Acidosis because of hyperventilation and respiratory failure. Sepsis is very much go hand in hand in AL. This is because of hyperinflammation. There is a immune dysregulation. And because of translocation of gut bacteria, they are more prone for gram-negative sepsis as well as gram-positive and anaerobes also. Now, if you see the investigation, there are different panels of investigations. I will mention first the routine investigation that should be done in all patients. That routine electrolytes, sodium, potassium, chloride, calcium, phosphorus, magnesium. Sugar should be monitored properly, particularly in case of infants. Complete blood count, reticulocyte count, blood type and cross-match, DCT, cholesterol, triglycerides, ABG, lactate, blood cultures, urinalysis, urine acid. Now, second set of investigations are done to design what type, how much is the acute liver failure. That is ALT, AST, GGT, total conjugated and unconjugated bilirubin, and PT-INR. In some special situation, you can also need to do factors 2, 7, 9, 10, which is liver dependent, factor 5 and factor 7. If the factor 8, if the factor 8, as I mentioned, factor 8 reduced, then you should consider DIC and you do fibrinogen and FDP products. Now, albumin is then to know the chronicity of a liver failure, and ammonia for the staging for the hepatic prognosis of hepatic encephalopathy. Now, third set of investigations are done for the cause. Now, if you suspected the paracetamol poisoning, you should do the paracetamol levels. IM, do the serum amino acid level, alpha and antitrypsin alpha level. Carnitine, acyl carnitine, if you suspected fatty acid oxidation defect. Mitochondrial disease, lactate pyruvate ratio. Galactosemia, then urine reducing substances, and galactose 1 phosphatidylidyl. Autoimmune hepatitis, then quantitative IgG, alpha smooth muscle actin antibody, liver kidney microcephaly antibody. Inward error, then see the results of newborn screening, serum ammonia and organic acids. If you're suspecting the viral hepatitis, do all the viral titers, which is hepatotropic A, B, C, D, E, CMV, adenovirus. Drug intoxication, then urine and serum drug levels. Wilson's serum, copper and seronoplasmin. Gestational, that is GARD, which is also called as a neonatal hemochromatosis, ferritin, TIBC, and HLH to fill the HLH criteria. Now, third set of investigation. So, how much complicated your ALF is? So, if there is CNS involvement, as we mentioned, ammonia should be done, staging, EEG should be done, and head imaging for the bleeding or to rule out the CT, to rule out the edema. How much is the edema? cardiovascular affection by the ECG, BNP, troponin, echo, renal by renal ultrasound, creatinine, urine output, and urine analysis, pancreatic amylase lipase, hematological DIC panel, INR for the continuation, and take for the coagulative staging, endocrine cortisol level. Some of the shocks are not responding because it is affected by the sepsis. So refractory shock, you should consider doing the cortisol level. And if you're there is always chances of sepsis, so you should see for the blood, urine, and sputum cultures. Now, imaging. Not each and every patient should go through all these investigations, but if you want to see the liver vasculature or type of liver, do abdominal ultrasound with Doppler CT angio. For cerebral edema, bleeds, brain CT, metabolic disorders, you should do the brain MRI. If you suspected GARD, then body MRI to further extrahepatic deposition like salivary gland, heart, and pancreas also. If you're suspecting HLH, hematological malignancy, then bone marrow aspiration. Iron deposition, then salivary gland biopsy, and mitochondrial muscle skin biopsy. There are few tests. If you are going for the liver transplant, do the ECG, echocardiography, albumin, pre-albumin, blood typing, cross anti-A and anti-B bodies. Now, what is the treatment? Now, majority of if you know the etiology, I think, I don't know, but in that case, 40 to 45% liver has a high chances of in the reversible mode if you know the etiology of a disease, and you can prevent the liver transplant in this patient. The most common is a paracetamol intoxication. In that, you should use the NAC, and the treatment should be continued intravenously until INR and transaminase level normalize. Mushroom poisoning, you should go for the penicillin, and you can use as a NAC and adjuvant. Before 2003, probably King's College has mentioned use of NAC in each and every liver failure patient. But around 2017-18, they revised these guidelines and they should restrict this for the paracetamol intoxication. But giving NAC probably doesn't cause any harm. HSV use the acyclovir. Adenovirus and CMV use the cidofovir, but it has a renal toxicity, so should adjusting the renal dose, and prehydration and propinicide should be used. Hepatitis B, entafilin, tenofovir, adafovir, interferon alpha 2 immunoglobulins. Autoimmune encephalitis, corticosteroid. Please see, whenever you are using any sort of corticosteroid, first rule out HSV, adenovirus infection, and malignancy before starting any sort of steroid. Wilson disease, like chelating agents like penicillamine, low carbon diet, and total plasma exchange. Sometimes they can also, for decompensation, they go for the liver transplant and albumin assisted dialysis. Urea cycle defect, low protein, high carbohydrate diet, and all the medical therapy, and SOS did for the LT. In idiopathic pulse, antithymocyte globulin and corticosteroids. Tyrosinemia type 1, elimination of tyrosine and phenylamine on oral NCTB, probably not available. We should ask from the US lab. HLH, that is IV aging, before pending the diagnosis, you should not use DEXA. And once the diagnosis is confirmed, dexamethasone, etoposide, anakinra, and liver transplant if the damage is irreversible. And in case of gestational autoimmune liver disease, double whole exchange transfusion and IVIG. So this is a treatment for the etiological cause. Now, this is a supportive PISU management. This depends on which condition patient will come. If the patient will come more than 3 to 4 stage of hepatic encephalopathy, then the patient should be admitted in the PICU. In case in PICU, in severe lives, as we mentioned, grade 4A, 4B stages, the patient should be intubated immediately for airway protection. And raised ICP, you should do the minimum stimulation elevation of 30%, 30 degree where hypothermia, barbiturate to decrease ICP, hypertonic saline with a goal sodium of 145 to 155. You should keep the ICP, if you are monitoring the ICP, keep the ICP below 20 and CPP. These are general management for the raised ICT. For decreased ammonia production, start with the lactulose, which can produce only 2 to 4 capsules daily, and a rifaximin for the bacterial things, and transfer the patient with resources to conduct liver transplant and albumin-assisted dialysis. Respiratory, intubate the airway protection and aim for the PCO2 between 40 to 45. Hypo and hypercarbia, which causes the secondary brain damage, which you should prevent, and your target PCO2 should be between 40 to 45. In case of CVS, as we know, there is a vasodilatory shock, so you should target age-appropriate MAP. As we know that it's vasodilatory, fluid resuscitation with the crystallites, and if you require 5% albumin, vasoactive agents like norepinephrine followed by vasopressin, that should be precisely used. If they is not responding, then you should consider as adrenal insufficiency and stress dose of steroids in the case of refractory. In metabolic, hypoglycemia, hyponatremia, hyperkalemia, you should avoid. Normal phosphorus value, which is very much required for the regeneration. Use isotonic salines, should not use this containing any types of lactate because of ALF. Lactate is not converting into the bicarb, so you are increasing your lactic load and causes more acidosis. Glucose infusion rates should be standard 10 to 12 mg. Maintain protein intake 1 to 2 mg per kg per day to avoid catabolic stage. Renal, avoid any sort of necrotoxic growth and any sort of vasodilatory shock. You should reverse it to prevent the HRS. And if at all there is HRS or AKI, use the CRR. Vitamin K should be started at least for the 3 days, although each and every time vitamin K is not efficacious. As we mentioned in the itself, that it is not reversible by vitamin K. FFP and cryo should be used for the clinical bedding and elective procedures and not for electively. Aminocapic acid for mucosal bleeding. Factor 7 is reserved only for the threatening bleeding after tried for a GIT bleeding. Now there comes the extracorporeal liver support. Now this ALS system has been designed to compensate for a failing liver. So whatever work done by the liver, that should be done. It can prevent encephalopathy by clearing the control spikes of ammonia, which is water resolving, removing unmeasured protein-bound toxins, maintaining hemodynamically stability by reducing circulatory vasodilators and bile acids, maintaining fluid and hemostatic balance, and progallant and anticoagulant. Based on technology used to remove protein-bound toxins, there are multiple non-cellular as well as cellular. Non-cellular like in details they are giving in this case because of constraints and because of time constraints. I'm not giving in details, but each and every system is superior. No single system is superior to another. Each and every time has an advantage and disadvantage, and there is no head-to-head comparison in children. In adults, there are some advantages to decrease the hepatic encephalopathy, but without any survival benefit. Use of this device at present is a research purpose. There are various types of advantage and disadvantage. I request our panelists to give some lights on this ELS support because they are the better person to mention to give the note on this type of therapies. Now, last is the liver transplant. Current statistics suggest 55 to 60% chances of spontaneous recovery. Although 40 to 45% child die without LT, this is given in that. I don't know current data. Criteria to determine liver transplant in FAL. Initially, that is the PEL score and MEL score. PEL score is used below 12 years and MEL score is used above 12 years. But there is no accounting for the extrahepatic organic failure. So there, King's College come with the criteria with paracetamol intoxication, as you can able to see on the screen. Arterial pH less than 7.3 or grade 3, grade 4 HE, and creatinine more than 3.4, and INR more than 6.5. King's College criteria for non-AP, INR more than 6.5, or 3 of all of 5 criteria. Patient age less than 11 years and more than 40. Cause is indeterminate cause, that is idiopathic. Drug toxicity, regardless of whether it is a cause of ALF. Bilirubin more than 17.5 milligram or more than 300. And jaundice or development of encephalopathy is more than 7 days. There is one status, that is a 1A, which has a highest priority for the liver transplant. Because of this is all the criteria, but I think our expert is more knowledgeable in these things, and probably last these two, liver transplant and ELS, probably our expert will give a better look rather than us. So my take home messages for majority of us, that ALF is a multisystemic orders with high mortality. Patients should ideally be managed with the multidisciplinary settings with facility of liver transplant. Early suspicious diagnosis, supportive line of management, early transport can change the whole scenario. A diagnosis of etiology like paracetamol poisoning, which is very simple and decrease the need of liver transplant. In PICU management, in hospital as well as during transport, all these should be taken care. Early airway respiratory support, decrease ICP by proper ventilation, hypertonic saline and position, maintain the map with the isotonic saline, albumin, norepinephrine and vasopressor. Avoid metabolic derangement because they causes the secondary brain damages. Effective only in clinical bleeding and procedure because it will causes the increase in water content or volume overload. If spontaneous bleeding, suspect not only coagulopathy but serious like sepsis. To date, liver transplant remains the only effective treatment. Liver assist device and hepatocyte transplant hold a great potential for a bridging to liver transplant or maintaining a patient while the native liver regenerates. Thank you very much. Thank you.
Thank you, Dr. Amit. It was an excellent, insightful, and very informative topic, and you have made it very clear to all of us. Now, I request Dr. Vishnu sir to give his expert comments.
Let me tell you, Amit, this is a vast topic and you have done really well. Some of the slides I think I should borrow you from you while giving the talk next time.
Thank you, sir. Thank
So
you,
it is really a vast topic, and the PCNA has came up with the acute liver failure before also and this time also. The certain things which I just wanted to highlight is the cause. So the yellow phosphorus poisoning is very much common in our area. So it is like a ratol which is ingested. I think one of the patient is from you only, one from the
Yes, sir.
Aurangabad and Buldana. So 3 or 4 patients which I have seen in last 1 year, and 2 of them got transplanted. So yellow phosphorus as a cause has to be thought about because many a times these children ingest, and if nobody has seen, then it gets unnoticed. The second is what we have not included, or what the PCNA has not included, is the genetic cause of acute liver failure. So now what is there is the one fever like a Ray's syndrome. So there are certain mutations like NBAS mutation or your Calfan mutation or KIF2 mutation, which has one insult and they develop the acute liver failure because of fever and they decompensate. Some of the fructose 1,6 biphosphatase deficiency is also present like it. The etiology I would like to divide age-wise, which Amit has also done it. So in infants or in young infants presenting with acute liver failure, we always suspect a treatable cause like galactosemia, tyrosinemia, and mitochondriopathy. These are the 3 most common cause, followed by GALD. Somehow I think GALD incidence has gone down. Maybe what we were reporting as GALD maybe something else. Okay. The older children, the causes you have mentioned, but in clinical practice, I find dengue is the most common cause in last 2 years. Means I have never seen dengue presenting so badly what we have seen in last 2 years. Unfortunately, the transplant is not answer for them. It is the only medical management. Hepatitis A, and in last couple of months, I'm doing one study with the NIV, and we are finding adenovirus, which is also a common cause of a liver failure. And it is true presentation we are seeing quite commonly, particularly last 2-3 months, a lot of adenovirus infections we are getting. The most common metabolic cause is Wilson. Though Wilsonian crisis is the difficult to manage, like what Dr. Amit has mentioned, AKI, acute kidney injury in the acute liver failure. Fortunately for us, we are not seeing AKI so much, except few conditions like Wilson, where there is acute hemolysis and that precipitates the AKI. Otherwise, in acute liver failure, we don't see a lot of AKI. But what is the most common cause of death in acute liver failure is not the bleeding, is not the shock, is not the respiratory failure, is not the infection. It is the cerebral edema. The first 10 days, 12 days, 15 days, only cerebral edema will be the troublesome thing. And that is why, as you mentioned, even your pathophysiology, the rifaximin, the lactulose or lactitol needs to be started to all acute liver failure, irrespective of the ammonia. And if the ammonia is high, put them on the CRRT. It is the best way to decrease the ammonia level. And once we decrease the ammonia level, the brain damage gets under control. The third thing is about the bleeding. It was very beautifully explained that it is PT-INR is not synonymous with the bleeding, because the procoagulant and anticoagulant both have decreased. So the ratio between procoagulant and anticoagulant is maintained, and they don't bleed. So there is no role of FFP. In fact, by giving FFP, the end organ damage will get increased. Okay, so that message is very loud and clear, and I am very happy for it. The tyrosinemia you mentioned, the NTBC is not available, but last 2 months there is one company which is Laurus Lab, which has introduced the NTBC in India, which is way cheaper than what we used to get from the Europe. And currently 2 patients we have already put on the NTBC, but it is the bridge, because it is not going to be a problem solver, but it is going to be a good for the young infants. The HLH, I think in HLH platelets gone down. So once the platelet goes down, your antenna should be up. That is it infection or is it HLH? Regarding NAC, we use it. You said there is no problem, but just remember that the serum sodium should be less than 150, 145 when we are using NAC. Otherwise, the sodium level shoots up to 150 to 160, and we have seen 170 also, and which is also detrimental. The prognosis wise, I am little skeptical about the 40-50% of the survival, because it was the probably a common survival what they talk. But those patients which present with acute liver failure with encephalopathy, the survival is poor in India. Those who have the initial first slide you showed, the hyperacute, acute, and subacute, and this is very, very important from the for us as a pediatrician, that if the child gets encephalopathy within 8 days of jaundice, the prognosis is probably excellent. So more than 60%, 80% children will not require a transplant. With the good management, they might improve and they will not have the end organ damage. The acute liver failure probably is the tricky one, and it is difficult. Whenever the acute liver failure patient comes to us, we directly put them on the CRRT. And we start with the plasmapheresis also to reduce the SIRS response, like what you said, the protein-bound substances needs to be taken out. CRRT doesn't take it out because it takes less than 20 kilodaltons. The extracorporeal liver systems, they came in the market with the big hope. They have researched well in the Birmingham and Birmingham where I was there. So they didn't came in a market as a replacement or a bridge therapy. Somehow they have gone down. But one point you have mentioned in the causes that I would like to mention for the pediatrician. We always think in acute liver failure or liver injury, the mefenamic acid is safe. But you mentioned that it has an idiosyncratic reaction. The paracetamol is dose dependent. So if you use paracetamol in 10 milligram per kg, it will not cause much harm. But if you use mefenamic acid and if it has an idiosyncratic reaction, you will not notice and child will have a problems. And regarding the status 1A, yes, all acute liver failure which comes to us, we list them as a super urgent liver for the liver transplant, and they get priority over all the waiting list patient. And whenever there is an organ available, they will be getting the organ in that zone. And probably from the 1st April, the organ donation will occur not on the hospital basis, which was used to be. So it will be a patient based. The PAIL score we are not using. PAIL score has gone down. So PAIL score is for the chronic diseases, chronic liver disease patient. Acute liver failure, it is the PTINR, bilirubin, and the King's College criteria, which you told. We are still following it. But the better is the factor 7 levels, which PCN has forgot to mention. If the factor 7 levels are gone down to 10 to 20%, then that patient definitely needs a liver transplant. But that is not in practice. But any patient with the PTINR more than 2, any patient bilirubin of more than 10, or encephalopathy more than grade 2, this patient needs to be managed in PICU, especially if there is a liver transplant center where there is a backup is there. So that center should manage the acute liver failure. Very well done, Dr. Amit. I must congratulate you. And
Thank you,
it is
sir.
one of the fantastic lecture which I have had. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir, for sharing your thoughts and experiences and really enlightening us on today's topic. Now I request our guide, Dr. Neman Mohanty, sir, to comment on both the research papers.
After a detailed discussion, I don't think anything is left out. Dr. Vishnu has cleared everything so clear. Only thing that we should know about this NAFLD, it's so common now. When I came in 2006 here in Navi Mumbai, we had a study where the obesity was hardly 5%. Now the obesity is going to 15% or more in schools. So out of them, about 30% might be going for the NAFLD. And that is the reason for the cirrhosis in later part of life. So many cirrhosis which are cryptogenic are labeled as cryptogenic earlier. Maybe because of this was happening, we never knew. So we should be very, very careful. And both the topics were selected to sensitize our audience that both are related to each other, and we do not land up in liver transplantation, to which most of our gentry, that is the public, is not affording. Thanks to Dr. Vishnu and others that they have come and started liver transplant in this region. In 2007-8, there was no issue for pediatric liver transplantation in Mumbai. Now we have several centers handling pediatric liver transplantation, and Vishnu is one of the leading persons. We are proud of you, Vishnu.
Yeah.
Thank you.
So I never thought as a pediatrician, when I took a pediatric, that I thought I will be taking the patients 1 kg, 5 kg, 10 kg, 15 kg. But now when I going to visit in Mumbai or Pune, when the patient comes, an 11-year-old child, 104 kg weight, 96 kg weight. So I was thinking that, am I sitting in the adult clinic? So that is the severity which we are seeing. Maybe in couple of decades, we will be in the big epidemic of the obesity, rightly as Dr. Mohanty was saying.
One point I will add, as Dr. Vishnu has also brought out, the prognosis of acute liver failure. In one study in SGPGI Lucknow, I believe, they have related to first when the reporting, the patient reports, the INR, they have linked this INR level to the outcome of the acute liver failure. That is Ansu's Srivastava study, I believe.
Okay, sir.
Thank you. Nothing else from my side.
Yeah.
And congratulations to both the presenters. Excellent work done. Thank you very much.
Thank you so much, Mohanty, sir, for your guidance. And now I request Dr. Jay Bhandarkar, sir, to take up questions if anybody has. I guess in the chat
On
box, there are no
YouTube,
questions.
Are there any questions? Pallavi ma'am, any YouTube questions?
No, ma'am. No YouTube questions.
Okay.
All the queries
Here
have been
also
solved.
Yeah, and it was an extensive article. Yes.
Thank you, ma'am. Thank you.
I thank our today's speakers for their excellent presentation, and I'm also grateful to our experts guest of honor and guide, Dr. Mohanty sir, for guiding us at each and every step. More important, I would like to thank all the doctors for their patient listening, who devoted their time and attention and participated in today's session. And I'm sure we all will be looking forward to similar informative and enlightening session next month. And now I request Raigad IIP Secretary Dr. Ajay Kohli sir to present the formal vote of thanks.
Yeah, Dr. Ajay is unable to join. Dr. Vikas is there. Dr. Vikas, will you like to give vote of thanks or shall I?
Definitely, madam. I will do this.
Thank you. Yeah,
honor.
please.
Yeah. And initially, I really thankful to my dear friend Dr. Vishnu, who has, as always, given a very simplified expert comments. And Dr. Vasant Karatkar sir, he initially came and joined us and gave us his blessing. Dr. Bharti Khairnar and Dr. Amol has given, Amit Chavan has given excellent presentation. Initially, it was looking a very difficult topic to begin with, but as the time goes on, both the presentation make that subject very simplified, so that all the audience understood the topic very well. I think this is today's the record breaking presence for this journal journey. We have crossed almost 60 marks. So, like MMC grade point has really contributed to this, I think so. There should be always an incentive for the presence, I feel. So I actually thankful to Dr. Ramakant Patil sir and Dr. Amol Kaur for taking the lead and making this journal journey with a MMC grade point. And at the end, I cannot I short of my word that to thank our respected Niman Mohanty sir for blessing constantly for this initiative from IIP Raigad, now taken by MAHAIP. And Swati Likhitu madam, you are always fantabulous as always. Then Chitra Kulkarni madam, Neha, Vishal, so many people behind this. Mind you, this looks a short 2-hour presentation, but since last 1 month, madam is taking a lot of effort, Chitra madam. And thank you. I'm just, as an IIP president, I just coordinate, but all the people are working really hard for this. So as I requested initially in my few words that if we can cover the different cases from the different systems, so that the people will get more benefit of this journal journey. Thank you so much for this presentation. And I now, can I conclude the meeting, madam, now with this?
Yes, yes.
Thank you, madam. Thank you so much.